It works better like this. Can you hear me? Good. Thank you. So, welcome everybody to this session on overdose prevention here in Warsaw. My name is John Melhus. I am from the organization EuroNPUD, which is the European network of people who use drugs. The name leaves no mistake. And I've had the honor to moderate this discussion today. Presentations, actually. I'm also connected to the Norwegian Association for Drug Policy. So, each speaker will speak for 10 minutes about their specialized field. I would like to make a small little talk about overdose prevention in general before they start. So I'm stealing a little bit of your time, but I'm going to try to be short because we would like to have a discussion at the end. So if you have questions to the speakers, please write them down or put them in the app so that you remember them and that you can ask them after we're finished, yeah? Then I think we'll try to take them in order. Overdose prevention. If we take into account what's going on in the world at this point of time, we have the Taliban have been very successful at eliminating the opium growers in Afghanistan, and at the same time, we're actually also seeing a lot of new, potent synthetic opioids on the market, we may be in for a rough ride. Luckily, we have these presenters here who have their own unique way of addressing this. And if I may, I would like to just go through a tiny little list of things, because overdose prevention is not just one thing. It is a number of things we should all consider to make available to our citizens at this point of time. And it should be like a collective strategy where you have all of these points where, in order to combat overdoses. And drug law reform is one of them, of course. Drug analysis services could be another one. You have drug consumption rooms, definitely a go. You have developed new technology to address this risk is important, and investing in, for example, low threshold OAT, opioid agonist treatments, could also be an important thing to think about. Also to think about reducing the control routines of people using services is definitely worth considering. I will stop talking because we have these esteemed guests here who are experts in their own special way. So, Swathi, would you please go ahead?
Hi, everyone. I'm Swathi. I am an overdose prevention care coordinator at Boston Healthcare for the Homeless Program in Boston in the United States. Thanks for having me. This is my first spoken presentation, so if I speak too quickly, just give me a thumbs down. I get a little excited and I start to yap on. You might be wondering what an American is doing here at the European Harm Reduction Conference. It's a good question. As many of you may have guessed, I am from the States, Ohio in particular, which is a state that's been hit quite hard by the overdose crisis. I lost several friends when I was pretty young, in my 11, 12, 13 years of age. But when I was an undergrad, I started wondering, okay, what can we do about this? And a lot of folks looked to Europe. Europe in many ways has set the standard on overdose response, even though there's ways to go. And I started thinking, I have a lot to learn from other people. Do we have the clicker? Yeah. Thank you. And it led me to wonder, excellent, how can we learn from each other? We have conferences like this, but obviously not everyone can attend them. A lot of the folks doing this work are busy doing this work, and they're not able to come abroad and talk to other people and share what they're doing. So I wanted to think about, how do we facilitate community-based learning? How can we learn from the ground up? Obviously, there are incredible policies, national policies around the world that we're learning from, but a lot of folks doing this work that have inspired that are grassroots activists. There are people who use drugs, people who formerly used drugs, their friends, their family. And those folks, their voices aren't always included in a wide enough platform for people to learn from. So I started thinking, okay, what is a way to share this knowledge in a more accessible, non sort of travel-based or financially, speak lower. Slower, yeah. I guess that was gonna happen, sorry. So how do we facilitate this knowledge, basically, the community-based knowledge in particular? So I applied for a grant after finishing my master's and had a year-long sort of project to document overdose response. I was in 4 continents, 14 countries, I think that number is now 18, more than 20 cities, doing over 100 interviews. It was overwhelming, but incredible. Now the team has expanded to 8 people based in these regions, continuing the interviews. My methods were numerous. I included photography. This is a photojournalism project. I wanted folks to see, what does this work look like, rather than, I think, a lot of the photography, which is of people using, and I think that's very exploitative. I wanted to photograph the people doing this work. What does outreach look like? What do your OPCs or DCRs or SCSs look like? What does outreach mean and look like? So I started photographing some of this response. I also conducted interviews, like I said, over 100 with folks doing this work, folks who use these services, people who said that, we have something to say, we want to tell you what's been working, what's not been working, what can other folks learn from us, what do we expect for our communities, what are we hoping for? And in addition to all of that, I conducted it alongside fieldwork, which was doing site visits to these services, joining folks on outreach, shadowing care providers, shadowing folks who were outreach workers, peers, trying to see, okay, what does this look like on the ground? Tangibly, my output is not going to be academic. I don't want to write papers that you have to pay to read. I don't want to write them in really scientific jargon that not a lot of people get to read. I wanted to make it in a very publicly accessible platform. So it's going to be a website. It'll have transcripts of all of these interviews in the languages in which they were conducted and in English. Interviews that were done in places like Portugal, Brazil, I did in Portuguese. Interviews done in Spain were done in Spanish, etc. I'm also going to include city and state profiles, which is some of the academic research on these places, telling you a little bit about, hey, when was the first syringe program? When did the first, heroin-assisted treatment program start? How many syringe service programs do you have? All of that. There's a multimedia part of this project, which involves a podcast, which I'm excited about. So taking topics and connecting them around the world. For example, what does mobile technology in overdose prevention look like? And thinking about how, when we have, say, technology in, bathroom sensors, and folks have apps, and folks have wearable sensors, which I think we'll hear about, how do these different technologies translate? And then there's a lot of writing in this as well, so people who are going to be communicating connections and themes between places. There are over 10 of those already written. And a photo journal, which is like joining in outreach, saying, okay, here are photos of different moments in the day joining these folks in outreach. What went on? What can you see in what a day in the life looks like? I think there are a lot of preconceptions outside of this community about what happens in day-to-day harm reduction, but this is actually meant to sort of dispel some of those myths. So here's just a little bit of some of the photography and description of outreach. So on the left is a mobile methadone van in Lisbon, and on the right is a social service agency also in Lisbon, which I followed each for a day, just sort of talking to folks who use the services, talking to the folks that run the services, getting to learn a little bit about that. The number 10 next to the word outreach is the number of different places I conducted outreach in with these communities. I was always invited by an organization, always joining them, always deferring to them on what they wanted to see, what they didn't want to see, and always kind of letting them lead. There's also some site visits. I did around 50 site visits at organizations that run services. On the left-hand side is in Zurich at EuroNPUD, looking at their diacetylmorphine, diamorphine, buprenorphine programming. In the middle there is the Manzaneres. There was a really kind of moving plaque that I saw at the very back in one of their open smoke spaces. That says, in memory of the victims of the war on drugs. And it's just kind of a reminder to us about that. and what this work means. And on the right-hand side is the very bright lime green DCR that sits in that shipping container in the middle of Geneva, kind of getting to see and juxtapose these spaces, how folks see DCR, some of them as very individual spaces and solitary spaces, some of them as very communal. What does that reflect about these communities and what standards that they set? And getting to put that all in one place where you can now walk through these spaces digitally with these photos and with the comments of the folks that run them alongside. Continuing site visits, I was in Amsterdam. I looked through all of the documents at Mainline, well, not all of the documents, lots of the documents at Mainline, which has been producing literature on HIV from folks who have HIV since the late 70s. I was at Men's Home in Copenhagen, looking at some of the programming there and all the different sites in that complex, including what is pictured here, which is, they, as a contingency management protocol, help folks sort of bagged at this bicarbonate, and they give small financial support to those folks, and these are all folks they use who decide to volunteer to support the Men's Home team. And then on the right there is Prinsen Mottech Center in Oslo, which is actually a very beautiful historic yellow building in Norway that they turned into a harm reduction center and operates as a CTR as well as like emergency respite. So interview-wise, you might actually recognize a few people here. I've interviewed over 100 people and counting. A lot of the questions that I ask they start with, what do you do? Who's the audience you serve? What's the demographic of that audience you serve? How long have you been serving them? How has the response changed? Tell me a little bit about the type of work that you do. Describe your services that you offer. What are the successes that you've experienced? How have you experienced them? What have enabled those successes? What are the challenges that you face? How have you tried to, defeat those challenges? What has been the biggest obstacle in your way? Is it politics? Is it funding? It's likely all of the above. Is it, social barriers? What are you seeing? Who is included in this response? Who is not included in this response? And in these kinds of questions, I really try and pick out, the voices of people who I think have been excluded historically, and creating this kind of digital archive of these voices so that people can participate. And the one question, well, not the one question, but one of the questions I ask every single participant in this project at the very end is, are you hopeful? And you'd be surprised to hear the range of answers I've received, which range from, yes, of course, well, how could I do this work if I wasn't, to no. And that tells me a lot about the type of environments that we're working in, the battles that we're often fighting uphill, that even with success upon success in some places, there's so much further do we have to go to reach all the people who need to be supported, and that the folks most equipped to do that reaching are the folks who live this every day, who have experienced this every day. And then that, has been something that I've really enjoyed learning about. So some of the key takeaways, I'm not really sure how much time I have left, probably not a lot. Common issues out here, finances are among them, politics, bureaucracy, there's a whole long list I can give you. We're happy to talk more about that. There are a lot of shared sentiments that people are experiencing. There's a lot of passion for this work. I think that comes with having chosen this. It's not a field that a lot of people in our day-to-day lives choose. But we have all chosen this for either a very personal reason, a very pragmatic reason, an empathetic one, a sympathetic one. And I think that that's really impressive. But it also means that there's a lot of burnout, that folks are so emotionally invested in this work that it's very hard to let go when you go home at the end of the day. And that's really, I think, difficult. And we have a lot of conversations at this conference about how to manage that and hope that we can sort of be mutual supports to each other. There is also a lot of hope that, while there's a long way for us to go, that we can learn from each other, which again is the heart of this project. There's also nuance in how we've approached our response. Some of that is cultural. There are similar goals that we have. Preventing preventable death is one of them. Preventing disease is another. Embracing joy and love, which I think often when health is our standard, we forget some of that stuff. There are very different ways of approaching that. When funding, for example, falls under HIV largely, then there's only a limit of what you can do within the drug response space. And so differences in funding structures impact responsibilities and how people carry them. And harm reduction as an approach that we add on to our health response, or something that should be integrated in everything that we do. Seatbelts are harm reduction. How we approach crosswalks is harm reduction. If we can think a lot about what harm reduction means, not as an add-on to the work that we do, but as very much a part of it in everything. I think that is something really beautiful I've seen as well. DCRs, like I said, as social spaces or individual spaces, again, how that reflects our communities. And I have some of the photos here of different sort of DCRs. You can start to see, one that's kind of part of Methadone, that's just, two on this little side right across from some of their day beds. On the right-hand side, I think, is Prinsen in Oslo. And, on the top right, we've got drug checking services and men's home. And on the top left is like strategies of defense, of our self-defense. And it's a very beautiful artistic sort of design that folks in the community built in Metsanides, which I found really moving. And the most important, I think, is that a lot of this innovation comes from communities. These movements have been led by folks. There's commonly nothing for us or about us without us. That is very much the lifeblood of this response and continues to be. And remembering that, I think, is important, but most importantly, implementing that and making sure that folks not just have platforms to talk, but the resources to do so sustainably without having to expend as much energy having to defend themselves is super important. And you can see, or I've seen rather, over the course of this past year and in the 7 years before involved in harm reduction from a pretty young age, that the communities that embrace that have the most success. So that is a really quick presentation of a year's worth project. I'm happy to talk about it more. It will be on this website eventually, I think probably by January, fingers crossed. I can be reached by email. Sorry for speaking super quickly. Thank you for having me.
Thank you very much, Swathi. It was excellent presentation. I'm sure to have a look later. There's one slight practical thing which I did not follow in the beginning of this either, but there is a translation service going on, so maybe we should try to speak a little bit slower. So my apologies that I did not say that in the beginning. Next speaker, Nicholas.
Thank you. Now, if you don't mind, I'd rather stand up while presenting, because this will help me to take a look at the slides as well. Okay. Okay. Now, over the next few minutes, I'm going to talk to you about the steps which have been taken over the recent years in Greece in order to expand the naloxone legal framework and to make the accessibility of naloxone easy to anyone. First of all, I represent the Greek Organization Against Drugs. The Greek acronym is OKANA. OKANA is the biggest service provider in the field of addiction in Greece, and almost 75% of all of the total number of people who use drugs and they attend a therapeutic program, or either they receive harm reduction services, they are OKANA's beneficiaries. As we all know, the risk for a person who uses drugs to have an overdose during his lifetime is quite significant. But the most significant thing is that overdose episodes occur in the presence of other people, either if these people are their relatives or peers or anyway other people. So these other people can actually intervene to reverse the overdose if they have the means and the tool to do so. Some, very little data about in the year 2021, official data, in Europe they were reported 6,600 deaths from opioid overdose. This number is considered to be underestimated because of study limitations and because in some countries they don't collect data about overdose deaths, and even in other countries the data that are collected are not very reliable. So the number is underestimated. Anyway, in Greece we have each year 150 up to 250 overdose cases. Well, let's skip this. And all international health organizations or organizations and institutions whose scope of action is the field of addiction, they strongly recommend the use of naloxone, and that every person who is likely to witness an overdose, an opioid overdose, must have easy and direct access to naloxone. We know about the take-home naloxone programs and the peer-to-peer distribution programs, which are run in many countries all over in Europe and all over the world. Something that I think it's important and shows how fast the field of addiction changes is the fact that within 5 years, from 2017 until 2022, there has been, in the United States, there has been an increase 700% in the prescriptions dispensed to adolescents between the ages of 10 to 19. So a 7-fold increase within 5 years in the prescriptions dispensed to adolescents in the United States. And that shows how important is the naloxone. Talking about the naloxone legal framework in Greece, as I told you, over the 3 to 4 years, the last 3 to 4 years, the legal framework has changed so that the access to naloxone is now direct, and that happened in 2 steps. The first step was done in 2021, where not only doctors and nurses, but even healthcare professionals, street workers, prison staff, and first responders were able to administer naloxone. And the second and most important step was done in March 2023. Ever since, naloxone is available to everyone in Greece, and everyone can administer naloxone if that is needed. Over the last 2 to 3 years, there have been reported 450 overdose cases, which have been successfully treated by the use of intranasal naloxone in harm reduction and health emergency services. And also, there have been 640 people which were trained about how to administer naloxone. So we can say, we know, and with confidence, that with the expansion of the naloxone institutional framework, at least some hundreds of human lives have been saved. Now, at Okana, over the recent years, it's not only naloxone. To prevent overdose deaths, we have taken some key initiatives. The first one is the establishment of the drug consumption room in Athens, which was the first DCR in Southeast Europe. A very recent development is the mobile drug DCR in the city of Thessaloniki that has been in operation for a few weeks now. It is a very recent development. I have just described you about the expansion of naloxone framework. Greece participates in the ESCAPE project of the EUDA, the project where syringes from the field are collected and analyzed. And Greece is the first European country to participate in the project with 5 cities. And the next steps that we are planned to implement over the next year is the establishment of a new toxification and overdose reference center. These are steps to prevent overdose. so that we can have a real-time knowledge at national level about poisonings and deaths, to develop take-home naloxone programs and peer-to-peer distribution programs, to launch mobile low-threshold methadone units, 2 of them in Athens and 1 in Thessaloniki, and also to establish more mobile drug consumption rooms, 2 in Athens, hopefully, and 3 in the greater Athens area, the so-called Attica region. Basically, by doing these things, what we are trying is we try to enhance our harm reduction network and to improve the level of care we provide to our clients, to ensure that the coordinated service with other institutions, relevant institutions that they work in the field, to protect the rights of our beneficiaries and to overall provide a wide range of services within an integrated system so that we can achieve the continuum of care that people who use drugs usually need. I think all of us here, we try to foster a safer and more compassionate environment for individuals who have addiction problems, who face problems and challenges with addiction, envisioning a future where not a single life is lost due to overdose. Thank you.
Thank you for that really great presentation. Happy to see that Greece is also moving forward on distribution of naloxone. So now for the third speaker.
So sometimes I'm a little bit too long. My name is Olaf Ostermann. I'm from Munich and I work there by Condrops. Condrops is a big non-government organization with offers for different kind of peoples, and we have a big part of harm reduction services in Munich and in other parts of Bavaria. Today I have the honor to present some results of the 3 years take-home naloxone project Naltrain in Germany. Normally this presentation did Simon Fleissner. He was the coordinator, one of the coordinators of this project for 3 years, but he's not here today, so I have the honor to do this presentation. The background, because for the need of this project is that in Germany the drug-related deaths increased the last years. So we have the highest, 23, we have the highest stance of drug-related deaths since 20 years. More than 2,000 people died, 23, and more of 1,200 was related of opioid consumptions. And of course, naloxone is a possibility to provide avoid drug-related death, and naloxone should be used in the community all over, but we are not there at the moment in Germany. A short look at the history of naloxone take-home programs in Germany. Germany was one of the first countries worldwide with a naloxone take-home program. The colleagues from Fixpunkt in Berlin started a program 1998, and it runs 2 years with a founding of the German government. But after these 2 years, the founding ends, and Fixpunkt did it on a small way in Berlin further, but nothing else happened between 2000 and 2014. We had drug consumption rooms in some part of Germany, but naloxone, nobody talked about it. Berlin was so 40 distributions a year, but nothing happened. Then 2014 and 2016, some smaller projects rised up, initiated by some harm reduction services, so the EDH in Frankfurt, Condrops in Munich, or Vision in Cologne started with small projects. Most of them had a little bit funding from the cities for the trainings for the people who use drugs. And 2017, a little bit bigger project started in Saarbrücken, was founded by the federal state of Saarland. And then we had a bigger one, role model project in Bavaria, so where we trained 550 people who use opioids and distribute naloxone to them. And after this, 2021, Naltrain started with the main goal to spread out naloxone all over Germany. So the first goal in this project was we want to offer 40 trainings for 800 employees of 400 different drug aid facilities. So we want to first make the workers, give the workers the knowledge how you can use naloxone and how you can offer a training for people who use drugs and how you can offer naloxone to them. Then this trained employees of the drug facilities should train people who use opioids all over Germany, and our target goal was to reach out 10,000 people who use drugs and give them naloxone. If we reach it, you will see it later. So the main results, I have to look at my, okay, I have another 5 minutes. The main results, the train-the-trainer workshops, we did 74 all over Germany in 38 different cities, and we reached 870 employees all over Germany. And approximately 375 different drug aid facilities was reached out. So this was drop-in centers, counseling service, rehab facilities, some OST institutions and all this. Here you see where the trained staff come from, different facilities. So a big part came from the low threshold facilities. So all over Germany, or not all over, but in the big cities and then some smaller cities, we have a lot of drop-in centers. So a lot of stuff came from there, also from the counseling service, and also from prison. So we trained people who work in prison that they could offer naloxone in the prisons, and in some part of Germany it works, in other parts it didn't. One problem of this project was that not all trained people offered naloxone workshops for clients after the training. So only 30% of the trained professionals offered naloxone trainings for their clients in the first 12 months after they was trained from us. So we have a lack, and we're looking now what are the problems, why the other peoples didn't start a program in their facilities. But when an organization started naloxone trainings in their facilities, they did more than once normally. So they see, okay, it works, it's a good thing for our clients, it's good things for the people who use opioids, and we want to go further on, also if it's complicated sometimes. Yeah, and this was our concept. So the facilities or the workers should be offered some naloxone trainings for people who use opioids or drugs. We said you can do it in a group training with appointment with 4 to 10 people, or you can do it in short interventions. So maybe if in the needle and syringe programs you ask what kind of drugs do you use? Do you use opioids? Do you have naloxone? No. So do you have 10, 15 minutes time? I can explain it to you, and after that you get the prescription and you get the naloxone distribution. The law in Germany is you get naloxone only with a prescription. So we have the problem that we always need a doctor to do the prescription, and so it makes it really complicated, and you have to be, you need a lot of to go around the law a little bit to make it easier, but it works. Yeah, and now we come to the number of people who used opioids we trained, or the facilities trained all over Germany. You remember we said we want to reach out 10,000 people. At the moment, we didn't reach this goal. The trained staff offered in 79 cities all over Germany by 125 different organizations trainings for people who use opioids. And altogether it was 815 trainings where we get the dictionary questionnaire back. They reached out 2,400 people who use drugs, and 60% of the people who use opioids get the naloxone right after the training, because that's really important. Interesting is that the most of the trainings and the trained person came only from 4 federal states in Germany. One is Bavaria, the other one is Baden-Württemberg, North Rhine-Westphalia, and Berlin. So in the other parts of Germany, there was only a few trainings, and if you see in the eastern part or in the northern part, there are not so many trainings, or more or less non-trainings there. Here you see the different cities. All the red one is Bavaria. Why it is in Bavaria so many trainings over there? Because we have the experience before that. So we had the Bavarian Roll project 3 years before, and a lot of harm reduction services already know how to run a take-home naloxone project. And really important, we had the funding for this. So we get money from the Bavarian government to train people who use drugs and give them naloxone. In other parts of Germany, there's no funding for these programs, and so nobody will do it. Because it's more work, you have to do it, and you have to find the fundings and pay the doctors and all this. So that's one reason, because Bavaria is so good in this statistic. Another problem is the prescription. You see, we trained 2,400 people, but only 1,500 get the prescription. From this one, everybody got also the naloxone, and only 1,000 was health insurance prescription. The other 500 prescription was private prescription, and you had to pay the naloxone, or the social organization had to pay the naloxone. In Germany, it's cost 46 euros, so you have to think about it, how you can finance this. Because of time, only a short view on the naloxone applications. Probably that's not all application that happen in Germany. That's only the application we could document it. So we got the questionnaire back from the organizations. So it was 110 in this more or less 2.5 years. If you have questions to that, I can say it later on. And conclusion. So it's possible to establish take-home naloxone in Germany, but we are a long way from spread it out all over Germany. So we are not on the main goal we want to reach. There are some parts where you can't get naloxone, or nobody offers you naloxone. The problems are lack of funding. The harm reduction services or the drug aid facilities need funding to offer these trainings. Big problem is the participation of doctors. They have different kind of Vorurteile? Missed about it. They don't want to have it. They have, yeah, it's really complicated to get a doctor to cooperate. And we have also a problem with the hospitals, detoxification and rehab facilities. They say, okay, they want to get clean. They don't need it, naloxone anymore because they're getting clean, but they forget that sometimes after rehab, you try to use drugs again. So we have to do work there. Genau. For the future, I think also in Germany, naloxone should become a drug over the counter so that everybody can buy it in the pharmacy. Also, the doctors should prescribe more naloxone for the users. And we need the funding to offer these trainings for the harm reduction services. And we need the other parts to implement take-home naloxone everywhere where you work with people who use drugs. And if this happened, then we can save more lives. Thanks a lot.
Thank you very much, Olaf, for this presentation, also describing some of the challenges that you're facing and also the status of take-home naloxone in Germany. Thank you. Please take. No, it's Chris. Yes. I'm sorry.
Should say Chris on it.
It's never a meeting without some technical hiccups.
Hey, we're ready. Okay, thanks very much. Thank you, Sean, for chairing this session, and thank you for the opportunity to speak to everybody here about something which we are trying in England, and it's called WODAS, which is the much better and shorter term than a wearable overdose detection device and alert system. So when I'm talking about that, I'll be using the term WODAS because it'll take half an hour to say it. And my name's Chris Rintoul. I'm the head of harm reduction for an organisation called Cranston, which provides a number of services in the UK. Got it. Okay. So most of what we do is provision of drug and alcohol treatment services across England, but we also have other aspects to the services, things for young people, domestic abuse services, criminal justice services, and some housing services as well. But our kind of bread and butter and our background is in substance use services for adults. So just to give you a little bit of context for the UK, the total number of deaths in the UK in 2023 from drugs or drug overdoses was 6,620 people, which is a much higher rate of death than you'd find across other parts of Europe. And largely that's driven, unfortunately, by a north-south divide in the UK, probably a huge influence of poverty there. So in Scotland, in Northern Ireland, and in the north of England, overdose rates are much higher again than the south, which is predominantly a better off part of the country. I'm showing you here a picture of a result from a service called WEDNOS, which is also a big long acronym, but it's a testing facility that you can send drugs to. And this one was quite interesting. It was actually alerted to me by a colleague of mine, Alistair, who I think's here at the minute. And we've seen here that the person believed that they were buying heroin or intended to buy heroin. And what they've got here is a mixture of heroin and heroin metabolites and so on, but also xylazine and one of the nitazines. And nitazines has been the kind of the big worry in the UK for the last year and a half, but longer actually now. So where we have a sample there which is contaminated with a range of different drugs as well as the primary one, it's of great concern. So there's never been a more dangerous time to use drugs in the UK. Nitazines, fentanyl and xylazine are cropping up in various different parts of the UK and on lots of different drugs. So it's not just a heroin thing. It's in oxycodone, it's in promethazine. It can even be in synthetic cannabinoids as well. So lots of people who may not have any tolerance to opioids may in fact be ingesting nitazines, which are much, much more potent than morphine and heroin are. There are believed to have been at least 250 deaths related to nitazines in the drug supply in the UK in 2023. But the reality is we don't know, and it's probably a lot higher than that because there's a delay in testing, or there isn't testing done in all cases. So we don't really know, but we expect to see that number sadly increase in the following years. Okay, so the key question for us has been, can technology detect overdose and alert somebody to respond in a supportive accommodation setting? If you're old school, you would refer to supportive accommodation settings as hostels, or people where people who are experiencing homelessness might live. So that's the question we asked. And in order to try and answer a part of that question, or part of this question, and by the way, WODAS and other similar kind of technology-inspired sort of attempts are never going to be the silver bullet. They're not going to, prevent all overdoses from turning fatal. But everything we do has a part to play, and it may link into a broader system of overdose prevention and prevention of loss of life, in particular amongst a very vulnerable client group. People who are experiencing homelessness and use opioids or other drugs are typically at much higher risk of overdose than those who are housed stably. So our partner in the hostel or supported accommodation setting is FLIS, James, and that's in a little place in a city called Worcester in the sort of middle of England. And then we have Manchester Metropolitan University, represented by Dr. Lee Guo, who's the AI whiz and has helped us to develop this product and has all that mathematics and AI ability that we don't need. So, he brings that. Queen's University Belfast, Professor Anne Campbell, who may be known to a few of you. And actually this project came from a conversation that I'd had actually with Anne a number of years ago. I was just trying to think there, more than 5 years ago, but less than 10. And I remember driving on the motorway into Belfast in Northern Ireland, where I live, and we were sort of talking about, wouldn't it be great if we could find something that would actually be able to detect overdose at an early stage and could direct help to it. So that conversation stayed with me, and we've worked together between us, but also with lots and lots of other organisations and groups to try and bring this to fruition. And our own service in the Worcester area, where the St Paul's Hostel is, by the service manager for that county, Matt Burke. And now I'd like to see if I can get a video to play. There you have it. So that's just a little short video to show you what the device itself looks like. For those of you who are wondering whether that's going to last any length of time, it has no value because it doesn't record anything. There's no internal SIM. It's there'd be no reason to take it off unless you just didn't want to be made aware that you were potentially overdosing. But there's also limitations to it. One of the big limitations is the staff in the hostel can't respond to an overdose if it's outside of their facility, because they can't leave the building. They would need 2 to go at any time, and there's usually only 2 on duty. So that's an inherent kind of limit to the project. But we felt that it was worthwhile going for it and trying within the hostel. So that's just some of the structure and buttons. Really, it just measures a few life sign indicators. The clever stuff is in the AI in the background, which is trying to understand what is happening when an alert goes off or doesn't go off, and in order to reduce false positives and also false negatives, and make it more reliable over time. So on that then, so a change in a life sign indicator, for example, oxygen levels, heart rate, temperature, movement. On somebody wearing the device, information is sent to a dashboard in the computer or to the computer in the hostel, and that triggers the alarm, and that dictates or directs staff to the particular individual who may be experiencing an overdose. And as I've already said, then the clever thing is about the system itself learning and becoming more accurate, because false positives are a problem, but so are false negatives. So we obviously want to kind of iron them out in time. This is the project timeline. A number of different phases. So there's the design and the manufacturing of devices in the first 5 months, installation of the alarm system and testing of the devices on staff, trial runs, seeing how it was going. And then staff training in month 7 on how they would respond. And in fact, we did a year ago, we did a lot of comprehensive overdose training with that staff team. And what we were saying to them is, look, this is not any different to how you would respond anyway. So there's no difference in your response in terms of supporting somebody to breathe, administration of naloxone if required, and all that other stuff. But the device system is just something that will give you a bit of a heads up that there may be something wrong. And then the wearing of devices for 12 months by willing residents, and we did quite a bit of, the various different project partners made a lot of attempt to engage with people living in that facility, and by and large people have been really willing to engage and like actually the opportunity to be part of research. And then there'll be the evaluation. So where we are now, we're in month 8, so it's just going live. And we're learning all the time, and we'll no doubt learn a lot more as the months go on. So thank you very much for your time. That's just a link. If you want to, it'll tell you a bit more about the project itself. And if you ever want to get in touch with me, that's my email. Thanks very much.
Thank you, Chris. That was a very, it's good to see that technology is being explored to help us in preventing overdose, and it's exciting project. Thank you. Please.
Thank you. Thank you, John, and thanks to the organization for giving me the opportunity to present the Overdose Prevention Program of Catalonia. Firstly, I want to introduce my institution, the subject of addictions, HIV, STI, and viral hepatitis of the government of Catalonia, which is in charge of policy planning, implementation, and evaluation in the region of Catalonia in Spain. The Overdose Prevention Program started in 2009 and is an overdose training program that includes take-home naloxone distribution, and it's implemented mainly in the drug care network of Catalonia. There are currently 62 centers participating, and the majority are outpatient treatment centers, harm reduction services, and also therapeutic communities. And since the beginning of the program until 2023, we have trained more than 15,500 people, and we have distributed more than 16,000 naloxone doses. So if we take a look to the last data available from the REDAN study, which is a cross-sectional study conducted on harm reduction services that approaches risky and other behaviors among people who inject drugs, it shows that almost 70% of the interviewed people report to have received overdose training. Harm reduction services and treatment centers are the most common places where they receive this training. More than 66% of the respondents have ever used naloxone to treat an overdose, and 97% of the people knows what is naloxone and how to use it. So how the program works, firstly, from the subjectorate, professional training is provided through online courses. And afterwards, the professionals participating in that training must provide internal training within their teamworks in their services. In second place, every center must develop and adapt a framework protocol to describe how are they going to implement the program. And then they start to provide this training to non-professional trainees, mainly people who use drugs, but also close people like family and friends. After the training, naloxone kit is given with an ID card that identifies the person as someone authorized to carry the kit. And finally, when the person comes back to restock the naloxone, a questionnaire is filled by a professional asking what happened with the naloxone. If it has been used to treat an overdose, we ask where and when did it happen. Some basic information about the victim, like sex, gender, origin, and age. Also, we ask about drugs used previously and how was the intervention performed, and if the person survived. So the results I'm going to show you are from these questionnaires. They are slightly different to what you can find in the abstract that we sent to the conference, because by that time we only had we had analyzed the questionnaires until 2019, and we finally included all the questionnaires until 2022. Also, the analysis that we conducted is much more simple. It's only descriptive analysis. So as I said, 521 OD interventions were reported. Among the most common places where overdoses took place were public spaces like the street or private homes. The victims were in a 75% men, 18% women, and in a 7% it was unknown or unreported. The average age was 35 years old approximately, and they were mainly Spanish or from other European countries. About the interventions, the majority didn't perform first aid, like safety position or mouth-to-mouth breathing, and they either called emergency services. The main reason given for not calling 112 was the person recovered, that it wasn't necessary, or that they didn't have a phone at that moment. And when the respondents reported to have called 112, they were asked if they wait until the ambulance arrived. They only did it in 33% of the cases. We have a lot of missing data here, but the most reported reason was that the person recovered, that the person left, there were more people in the place, or that the ambulance never arrived. So only in 27% of the cases in which the person stayed, the ambulance arrived and took the person to the hospital. Here we have the drugs used previously. The most used is injected heroin, and sometimes it was in combination with benzos, cocaine, or alcohol. And only in 10 cases there was an opioid use reported, so in which case naloxone wouldn't be the indicated treatment. So in 87% of the cases, the victim survived. 6 people died. We don't have many information of what happened, but heroin use was involved in all the cases. And here we overlap the data of naloxone distributed per year with all the interventions reported. We can estimate that at the beginning of the program, 7% of the naloxone distributed was used to reverse an overdose. And this percentage has decreased over the years, and in 2020 it was only 1%. All the interventions took place in the street or private homes. The most involved substance is injected heroin, and we have seen also some barriers to provide first aid and to call emergency services. However, the survival rate is high, it's 87%. And this, the percentage of the naloxone use has decreased from the beginning of the program. Possible explanations of that can be the decrease of heroin use that we have seen in general, but also in drug consumption groups. We have seen also a decrease of overdoses in those services, and we have seen also a decrease in the presence of opioids in overdose deaths in Catalonia. So, you want to know more about our overdose prevention program? Here on the left side you have a short video with interviews, and in the right side you have the dial into the program section in our website. Thank you very much for your attention.
Very good. Thank you very much for that presentation. So now we've seen a lot of different aspects from many different countries. I was wondering, there has not been submitted any questions yet in the app. So I was just wondering, just if you have any questions, please.
Hi, thank you. And the question is actually for you. So, we've seen a gradient of the distribution of the success, let's say the success rate of the naloxone, which is geographic. Do you think it's only an issue of funding, or is it about a cultural divide within your country?
So I think funding is one important thing for that. The other one could be, but I'm not really sure, that in different parts of Germany, maybe opioids not so common. So in the eastern part of Germany, maybe Dirk, you can go on. In the eastern part of Germany, there are a lot of crystal and some amphetamines coming from Czech Republic, and also because of the former time of the eastern part of Germany, heroin was not so common over there. Maybe this could be also a reason that there's not so many places where you can get naloxone, because heroin or opioids not so common. Yeah, but I also think it's also a founding reason.
Thank you.
My question goes also to Germany. In the beginning of your presentation, I saw that 20 years ago you were pioneers in the distribution of naloxone. And sadly, I've seen you telling that overdose of opioids actually increased a lot. So that point of the prescription of the naloxone, it's a nonsense thing that I see here as a barrier, an obvious barrier to saving lives, and why you keep on having this prescription barrier. And if the drugs are being tested in the point of understanding why with naloxone distribution so widely, after 20 years, the overdoses are increasing. That's my question.
So the first answer, I think it's at the moment it's a political decision because we have a lot of regulation and law in Germany, and they said, okay, it's a medication, and you need only people who use drugs or opioids can get it, and the doctor have to decide if you can get it or if you can get it or not. That's only a political decision. It's not our decision. I think everybody who use opioids should get it, and every relative should get it, and every social worker who works with people who use opioid should get it. But at the moment, you need the prescription. So we try, and also I think the Deutsche AIDS-Hilfe and the project partners try to talk with the politicians. The Vorteil, the advantage of the prescription is it's for people who use opioids. When you get the prescription, you can get it from the health insurance, and you don't have to pay for it. That's the positive side of the prescription. But at the moment, it's a big barrier. And why it took so long in Germany, I don't know really. Nobody want to do. We had a part drug consumption rooms, and that was the big things 20 years ago or 25 years ago, or drug consumption rooms all over Germany. It's not all over Germany. We have parts of Germany we don't have drug consumption rooms, and for nobody think about it, naloxone at this time. And now we think about it, what are the reasons for the increase of the drug-related death? At the moment, we can't say it really. Probably there's opioids coming back. Yeah, so we had a couple of years where, especially young people, there was not a lot of use of opioids by young people. But now we see increasing rates of young people using opioids, and also we think the synthetic opioids like fentanyl, nitrazene, all this stuff probably will or is already there. We don't have really good data for that in Germany because we have less drug checking. Yeah, but I think this could be the reasons for the increase of the drug-related deaths in Germany.
A question for Chris. I appreciate it's the first iteration of that, but is there any tech that is present in the watch you've designed that isn't available in sort of current products on the market?
Well, to be truthful, I don't actually know. Can you hear me okay? I don't know. I know there are other wearable devices, which are, I mean, there's a bit of a kind of a rush on at this point in time, as you can imagine, given what's going on in the UK, particularly up north. So there's lots of different things being sort of worked on and trial. The actual measurements of what the devices measure is really pretty simple stuff, but it's in that background of it becoming more and more accurate and being able to actually more closely identify overdose or the risk of overdose occurring, in a very short period of time. Yeah, I mean, we wouldn't want to do something like WODAS just sort of, casting it out and sort of leaving it to a bit of luck, because, we have to have that support around for people if they should, need that. And that's why we have to put it into a kind of supported setting. But over time, there may be other things that we'll do, but we just have to get through this phase first to understand, does it actually work? And if so, why? And, what are the things that we can learn, to make it even better again in the future?
Thank you. Dirk?
Yeah, I would like to ask you, thanks a lot for the presentation from Catalonia. Do you need also a prescription for naloxone? Because I saw your incredible numbers you reached, and how do you do that?
Yes, we have the same situation than in Germany, that it's a prescription needed to give the naloxone, but actually it's a little bit difficult to explain because we are the Ministry of Health of Catalonia, so we don't regulate this because it's the Ministry of Health of Spain who does. But when the program started, we were very pragmatic. I mean, basically the subdirectorate bought naloxone, and that was already available in DCRs. So we put it in a kit and we distribute it to the harm reduction services and treatment centers. In the protocol that every center must adapt, must be a medical reference professional. But sometimes outreach teams don't have this figure. So the doctors that are working in our team, in the subdirectorate, take the responsibility for that. And over the years, now naloxone programs are included in the national drug strategy. So it's quite a paradox that they do include this in the national strategy, but they don't change the regulation to be over the counter. So we still think that it's necessary, of course, because we are here in a, it's a little bit tricky or dangerous to be distributing a medication that should be prescribed, and but yeah, I think it's a political also will, because it was very clear in our case that it was a necessary strategy. So the Ministry of Health of Catalonia, the region, took the responsibility of that.
Roberto?
Yeah, I have a question for Chris. I've noticed in many different projects that involve the introduction of digital technology or wearable technology when it comes to overdose prevention, there is a bit of a debate that has to do with the fact of, especially within housing contexts, the extent to which does the intervention that should be included or not, because it requires quite an investment on the technology development, buying wearable training, mixing universities and bringing. I'm wondering if you could explain it a bit about how did you approach this sort of decision of introducing the technology rather than maybe doing other type of interventions for overdose in the housing. Do you know what I mean?
Not really.
In the moment that you're developing this technology, I mean, there is quite of an investment of resources, economical stuff that you have to be doing for overdose prevention, and particularly within a residential setting in which you have already all of the community and you have the staff. There is also other possibilities to do overdose prevention. Why specifically did you choose for go for technological intervention? I'm not saying there is no need, but there is a bit of a big debate of are we using the resources correctly developing this technology? Is there any other type of more like community-based approaches that we could have, particularly when we have the community in one single building?
Just okay, get you now. Well, I think it goes back a bit to what I said earlier. I said that this is not going to be the silver bullet, but it's one of many things that is going to make a bit of a difference. We also were pretty much, the invitation really for this didn't come from ourselves, it came from the hostel, because there had been several people who sadly had died, I think in 2021 and 2022, and they had been long-term in that place, and it had caused quite an effect on the rest of the people there. So there's about 40 people live there. And, there were ceremonies to mark their passing, there was commemorations a year, 2 years later, etc. So all of the discussion about MODAS went on within that context, and it was really, it was an open door. People wanted it. People wanted to be involved in research which might protect their own lives, but also, protect other people's lives, because they've been through these kind of griefs and losing people within the place. The hostel themselves were very aware that, if you're going to respond to overdose, you have to know what's happening. And unless you know what's happening, and it's down to the gods whether the person survives or not. So all of these kind of drivers came together with it. But my general point again is that this is not the silver bullet, nor is naloxone actually. There's loads of different things that we will need to do to try and drive down the drug-related deaths rate in the UK, which is astonishingly high, and sadly most of all in Scotland.
Thank you. More questions? Yes.
Hi again. Now, this issue comes back again and again, also in Spain, about the prescription and the willingness of the medical doctors to prescribe. I mean, I'm a medical doctor. I find it extremely strange that the medical doctor would not prescribe. I mean, okay, let's say the bureaucratic overhaul and overload of that. But other than that, I mean, in medicine, we have a rule. When we prescribe drugs, any kind of medication, it's benefit versus risk. Now, what's the risk of naloxone? Come on, people. It's almost zero. Okay, so why are you denying the benefit? I find it extremely strange. Someone can answer, I think.
Maybe I can tell you two prejudices about naloxone in Germany from doctor's side. Some say if they got naloxone in their pocket, they will take more risk in their drug use. That's a theoretical discussion. I know that. But yeah, but that's what doctors respond to us. The other thing is, the main goal of opiate substitution treatment is to stop using illegal opioids. And they told us, is that okay that we gave them a medication for illegal use of opioids? Because that's not the goal of our treatment. That's not my position, but that's the position of many doctors in Germany. Yes. Yeah. Yes, you are right. I'm not the doctor, but I will explain you what we've heard and what the prejudices about naloxone. And many said, we didn't prescribe that. And so we got a lot of problems, but now, very new, we got the new guidelines for OST, and take-home naloxone is now in the guidelines as a medication who should prescribe for people in OST. It's very new, it will come in a few months, and that is a big step forward that is in official medical guidelines for OST treatment. And that happens after this project.
Thank you,
I'm Anaïs. I'm from Belgium. I'm also a medical doctor. I graduated 5 years ago. Louder? Louder? Okay. I graduated 5 years ago, and in my curriculum there was nothing about methadone, Suboxone, naloxone. So I think beside the prejudice, there's also a huge gap of knowledge. And I think one of the things that we can also focus on is maybe beside the peer-to-peer is focus on the curriculum in every country, and maybe that will help as well. I will try to do in Belgium. I realize now after this Congress, and I think that's something, and normally they, like the professors should let us do that, so I think that's one thing. Keep in mind.
Thank you. Anybody else?
I want to add an argument for which is, social workers and other harm reduction workers are often not being allowed to use naloxone in their services. I mean, at least in Austria. One argument is the duration of the effect of the naloxone. So if a person gets naloxone in a service, and then when the effect is blocked, and the person is like, "Hey, you disturbed my time," and then goes away in the park or maybe consumes another opiate, it could be dangerous. So I'm curious about your experience of these situations. Thank you.
Yeah, I'd like to answer that one if that's okay, or come in. Yeah, absolutely. I mean, naloxone is a wonderful last resort measure, but far better is early detection and early intervention, and in particular around oxygen. And we're working within a UK context, and the regulations around oxygen are really quite tricky. Thankfully, I have to say, like, I mean, I feel for those of you in some of the countries here who are finding it really difficult to get naloxone into people's hands. In the UK, that is not a problem anymore because we've had successive changes to legislation to make it more and more easy actually to supply it. That does not mean it's it's been successful all the time. It doesn't mean that it's always at the scene of an overdose. There are still people dying, as you know from those figures, but the regulation around naloxone is pretty good nowadays. I.e. it's lax enough to allow us to get it to many people. Our problem is that we're not in touch with the people who really most need it. It's like the inverse care law. The more at risk you are of overdose, the less likely you are actually to be involved with services or around people who might be able to supply naloxone to you. And that's why in the UK there's a lot of stuff going on around peer supply. And it's done quite well, actually, in a lot of places, very well, actually, in some places, and then other places maybe not so good. There's a kind of a big bang thing, do a lot of training, we give out 400 naloxone packs, and then, nobody carries it, But one of the things that I think might help for some of, our colleagues in other countries is when you do the training for trainers in naloxone, make sure there's somebody there to mentor those trainers so that they have confidence then to go on and supply it. And we've done that within my organisation. I did that within Northern Ireland when I worked on, take-home naloxone for about 10 years there. And it was whenever you had trainers confident and getting those mentoring opportunities, and then they can just set up and go. Because the thing is, if you don't use it, you lose it, And training is never, for me, the end outcome. It should be what do you do afterwards. That should always be the first thing you're thinking,
There's a few myths. Me as a drug user, and that we did already peer-to-peer training in order to replicate exponentially the distribution of naloxone. There's a myth that we make parties of getting super high because we have naloxone, which is bullshit because naloxone gives you a big withdrawal feeling. And I have a question. It is, for example, I was assisted myself with naloxone from a friend, and I was given 6 nasal naloxones, because of one speedball. And I don't know if there's a limit in the doctor's practice. In the response, the emergency response, a limit that for you to give the naloxones, if there's a number.
10 milligrams.
Okay, okay.
Up to 10
just to know. Okay, thank you.
Yeah, I'm going to chime in with some perspective from the United States. So this is not my project related, but I work in overdose prevention in one of our open air kind of encampments. And the US does have over-the-counter available naloxone. We have huge peer support programs. The first responders are majority peers and not law enforcement. And I'll just kind of give an anecdote. Last week we had 10 simultaneous overdoses because of one bad batch during like 1 hour period, right where I was working. And all 10 people were able to be monitored and supported and fine actually after about 2-3 hours, which was incredible. And that is because the people that were responding were peers. I also just want to say that the start of kind of, this over-the-counter was 2023, but before that, like local nonprofit organizations in almost every state had been giving it out. I was trained when I was 17. I've been carrying intranasal naloxone since then. And I think part of how that happened is because there was a activist in Chicago who came to Europe, put naloxone in a suitcase, brought it back to the US and was giving it out against, the law. But of course, like life doesn't, like there's no law limit to life, right? This is about survival and more than that. So I guess I know we're talking within legal frameworks and that is very important, but know that a lot of the progress in this field happened outside of those legal frameworks. So I encourage kind of that creative thought. I would also say that, in my experience, I'm trained to train people in naloxone. Training of trainers, I think, is very important. But I also would say that these folks that know what to do, right? Branding matters as well. We did so much in where I'm from on that intranasal 4 milligrams that people don't feel comfortable doing intramuscular, even though it is kind of more effective. You do give fewer doses and, precipitates less withdrawal. So there is that education component as well. We're now trying to put Revive, which is instead of Narcan, the 4 milligrams, it's 3 milligrams, which makes a big difference if you give 2, right? 6 versus 8. We're trying to move towards atomizers on 2 milligrams. So in my work, we're trained to do 0.5 increments, which is even better. And then we hook folks up to oxygen. But that's also resource dependent. So, I would say if your first priority is preventing overdose death, get naloxone out there and have these conversations about how to do so in a way that does not precipitate withdrawal, because then, like someone said earlier, you will distance folks from coming back to your services, which we see as well. People wake up and they're like, why did you Narcan me? Because we wanted you to survive. But there is ways to do that in lesser increments, add that oxygen, and slowly bring folks back.
Thank you very much, Swathi, again. And I believe we come to the end of our session. It's exactly on time, I think, or if I'm not mistaken. I would love it to keep on talking. I think there's a lot of people who'd love to continue the conversation. It does not end here. No, it goes on and on. But I think, as in summary, it is important to have a multifaceted strategy on overdose prevention. It should be shaped by, and that's another thing that's really, really important in this, and that is, please, everybody, keep on consulting the community, involve the people who use drugs in the work. People who use drugs know what's going on. They have the expertise of this. So with those words, I would love to say thank you very much to the panel for joining us, and thank you very much for joining us.